Hello again, and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, and I'm here with my brother and co-host, Rohit Gosain. We hope you're ready for an exciting discussion today. We're diving back into non-small cell lung cancer, but this time our focus is metastatic non-small cell lung cancer with no actionable mutations in first-line settings. To cover this, we're joined by none other than Dr. Isabel Preeshagul from Memorial Sloan Kettering Cancer Center. Isabel, welcome.
Thank you both so much for having me. It's an honor to be on this world-renowned podcast that I turn into to learn myself and stay up to date. So thank you both for having me today.
Well, that's very kind of you, Isabel. Thanks for joining us. To kick things off, imagine you're at a community oncology center and you have a patient in front of you with newly diagnosed metastatic non-small cell lung cancer. NGS testing on tissue and liquid was done. Unfortunately, no actionable mutations were found in frontline settings. What is your first move from the treatment option standpoint, and how does PD-L1 impact your decision-making here?
Sure. So I think, first of all, probably the most common patient that we see, right? We know that patients have driver alterations, and we always need to make sure that we obtain next-generation sequencing, regardless of histology. But the first thing that I look into is what is their PD-L1 status, meaning what is the percent expression of PD-L1 on their tissue. And this can be done at your institution, some via IHC, some via other panels. So we need to sort of stratify these patients first, 50% or greater. And if it's 50% or greater, they go into sort of the high PD-L1 expressors cohort, and I can talk about that. Or you look into patients with PD-L1 1% to 49%, or no expression of PD-L1. And it can get very, talking about tumor heterogeneity and biopsy technique, but I think really we need to just sort of determine PD-L1 positive versus PD-L1 negative. In addition to that, it's really important to look at tissue histology. Are we looking at somebody with adenocarcinoma? Are we looking at someone with squamous cell histology? Because the treatment algorithms and the options available differ based on your histology. So let's start with the easiest one, right? So let's say someone has a high PD-L1, it's greater than 50% expression. You have the most common option that we have here is based on KEYNOTE-024, which looked at patients that had, high PD-L1 expression, greater than 50%. They enjoyed a benefit with single agent Pembrolizumab over standard of care chemotherapy. So if you're seeing a patient in your clinic that has a high PD-L1 over 50%, Pembrolizumab might be a great option for them. However, I would like to make sure that you make sure that your patient does not have any underlying rheumatologic issue, whether that be lupus, scleroderma, rheumatoid arthritis, any inflammatory bowel disease, ulcerative colitis, some other kind of rheumatologic issue, discoid lupus also, psoriatic arthritis, because immunotherapy in patients that harbor these underlying rheumatologic issues can really exacerbate these issues, and it can become life-threatening. So it's always important to take a very thorough history before you subject your patient to any immunotherapy. But if you have somebody that has no underlying autoimmune issues, a high PD-L1, stage 4 non-small cell lung cancer, frontline treatment with Pembrolizumab based on KEYNOTE-024 is a very fine option. I do say that it's important to scan the patient after 2 cycles. So that would be 6 weeks of therapy, 1 dose every 3 weeks. And the reason for that is because you want to kind of take a peek and make sure that this is working, right? You don't want to just treat them and send them out to pasture. You really want to make sure that what you're giving them is the bang worth the buck. So you want to make sure that, number one, I always say this scan is not to make sure you're having a miraculous response, but to make sure that, one, there aren't any new spots, right? And 2, that the spots that we see have not gotten bigger. If we see a response after 6 weeks or 2 cycles, that's a huge win. But I just want to make sure this is not progressing. So I always tell my patients that, and if that scan looks good, then we can kind of plan for your next scan per NCCN guidelines, which would be in about 3 months' time.
And a few things to reiterate, you brought up underlying autoimmune disorders. I just want to make sure that is not a complete true contraindication. A well-controlled autoimmune disorder is something that, again, having that patient-centered discussion. Of course, this is very different if they have a transplant, liver transplant, heart transplant. Those are times when you are taking a pause and saying, I cannot use immunotherapy. Isabel, in this particular scenario, we're all getting very comfortable using single-agent immunotherapy. If there's high tumor burden, are you combining immunotherapy with chemotherapy, even with high PD-L1 score, for looking for a quick response, or you feel comfortable because you are in this scenario looking for a repeat scan in 6 weeks?
Thank you for that question. You led me right into my next thought. So you have someone that has a high disease burden. Sometimes you think you need to pack a little more punch than immunotherapy alone. And in this case, I tend to have sort of a risk versus benefit discussion with my patients. Patients that are really symptomatic, really feeling lousy, otherwise fit, and I think that they could tolerate concurrent chemotherapy and immunotherapy. We talk about this. So there's a couple different options in this space. You could go with the KEYNOTE-189 regimen, which is carboplatin, pemetrexed, and pembrolizumab. Or you could go with the KEYNOTE-407 regimen if you have squamous cell histology, which is carboplatin, Abraxane, or Taxol plus pembrolizumab. Or you could go with what we affectionately known as the quad, which is carboplatin, paclitaxel, bevacizumab, and atezolizumab. And there's other options and other ways to, there's also carboplatin, paclitaxel, Nevo-Ipi as well, which we can get into, but that wouldn't be my first choice here. I would say if you have someone with a large disease burden, my first choices would be, if it's adenocarcinoma, it would be carboplatin, pemetrexed, pembrolizumab based on KEYNOTE-189. And if they have squamous cell histology, it would be carboplatin, paclitaxel, or Abraxane plus pembrolizumab. If you really have someone with maybe poorly differentiated carcinoma, which we do see sometimes sarcomatoid, very angry features, sometimes these patients benefit from the addition of bevacizumab. So sometimes these patients, we talk about the Empower 150 regimen, which is carboplatin, paclitaxel, bevacizumab, and atezolizumab. It is by no means a free lunch. All of these have toxicities, which I'm sure we will get into. But, big disease burden, sometimes we give them a little bit of a punch with the chemo and the immunotherapy up front. And then we can always, curtail it a little bit back based on that response after 6 weeks.
Thanks for covering that, Isabel. In community, we are very comfortable utilizing single-agent immunotherapy with chemotherapy. Particularly, the confusion comes in when we have these dual checkpoint inhibitors, Ipi-Nivo or Durva-Tremi, and now you combine that with or without chemo. So what is your ideal patient when you are pulling off these tools, dual checkpoint inhibitors, and even on top of that, adding that with chemotherapy here?
So, when you're adding nivolumab plus ipilimumab to chemotherapy, you are adding, as you had said, more toxicity.
Right.
And I don't think, in full transparency, we know the perfect patient, that would enjoy a response from this. But if you're looking back at the data and the subset analyses, it does seem that patients, perhaps regardless of their PD-L1 exposure, but maybe patients that have a higher tumor mutation burden may benefit from the addition of nivolumab plus ipilimumab to their regimen. And what do I mean by a high tumor mutation burden? So we look at, when you're looking at someone's next generation sequencing report, you need to have the next generation sequencing report to understand what someone's tumor mutation burden is. It's a calculated score that is based on megabase pairs. So if you have 10 megabase pairs or higher that are mutated, that is considered a high tumor mutation burden. So let's say you have someone with a high disease burden, right? A tumor mutation burden of 26, a PD-L1 of 1%, maybe carbotaxel Nevo-Ipi might be a good regimen for them. But I can't say that I would choose that per se over carboplatin, pemetrexed, pembrolizumab, or carboplatin, paclitaxel, or Abraxane, pembrolizumab. It's just yet another option. And if you want to get into the weeds about things, if you have a TMB, that may be an option for you.
Isabel, can I push a little further on this topic, because again, this whole dual checkpoint with chemotherapy seems so elusive with higher toxicities. But now you have NGS, you have higher TMB, the PD-L1 score is low, STK11, KEAP1, TP53. Are you using some of that information as well to lean towards this dual checkpoint inhibitor combination?
So in some cases, we know, so let's backtrack a little bit. We know that patients that have these co-mutations STK11 and KEAP1 are bad players, right? We know these patients typically don't enjoy a response to immunotherapy. And sometimes we see them, in combination with KRAS alterations. And someone with a KRAS alteration, unfortunately, at this time still gets treated with chemotherapy and immunotherapy upfront or immunotherapy only upfront. There is no targeted therapy in the frontline setting for patients with a KRAS G12C alteration or KRAS alphabet soup, whatever it may be afterwards. So I think sometimes I use this as a way to kind of guide how I expect patients, how I set expectations about how I think patients will respond to treatment. And I may say, in addition to your KRAS alteration or on your next generation sequencing report, we didn't notice anything actionable. However, I did note that you have 2 co-mutations, KEAP1 and STK11. And unfortunately, we know patients that harbor these alterations tend to have a worse prognosis and tend to not enjoy as much of a response to treatment. So sometimes for these patients, I think we need to give them a little more upfront than less. But it needs to be a case-by-case discussion. You have someone that's older, you have someone that's frail, you have someone lots of medical comorbidities. Throwing everything but the kitchen sink at them may not be the best thing for them. And you never know. Sometimes these patients that get combination therapy with chemotherapy and immunotherapy, you never really know which is really driving the response here sometimes, right? So I think it's a risk versus benefit discussion with each patient.
Now, the same patient, unfortunately, the disease was to progress. In second line, as of now, we have KRAS G12C. Isabel, you've alluded to this already. The other targeted option is EGFR Exon 20, likely to move in frontline settings. And then you have HER2 mutation. Starting with KRAS G12C story here. Isabel, your thoughts? This is finally a targeted mutation, but by no means this has been a home run when we're comparing it to docetaxel.
Yeah, correct. And I do want to just backpedal a little bit that anytime you have a patient in your clinic, regardless of the stage of their disease, you need to think about clinical trials in the upfront setting, right? So
absolutely,
we are talking about a patient that is not eligible for a clinical trial. Sure. So I think if you have a patient with a KRAS G12C alteration that's progressed on frontline treatment, I first want to know, are they having oligo progression, meaning progression in one site while everything else is quiet? Or are they having progression diffusely, right? So if it's oligo progression, then my gut is always to offer local therapy options, whether that be radiation, whether that be IR ablation, cryoablation, or even a resection, if that's possible. So if that's possible, that's the road that I go, and I continue the same line frontline therapy. However, if it's diffuse progression and you don't want to go play whack-a-mole, then you need to think about what other systemic therapy options we have. So there's 2 FDA-approved agents for patients with KRAS G12C alterations that have progressed on frontline therapy. And one is sotorasib and one is adagrasib. Both of these are pills that target your cancer cells that have the KRAS G12C alteration. So between these 2, I think if you really go through with a fine-tooth comb, there is some finite data that patients that have CNS metastases may benefit slightly more from adagrasib. So someone that has brain metastases or progressive brain metastases, I might consider leaning more towards adagrasib. But if there are no brain metastases, I think it's really just what can you get for this patient? I don't think there's never been a head-to-head trial, and I don't think there's ever going to be. You need to look into it, insurance authorization, and also thinking about, patients and dosing. Sotorasib is quite a lot of pills that you need to take per day as opposed to adagrasib. So maybe you have someone that's not as compliant that has, a very high pill burden. Adagrasib might be a better option for you. But if you have somebody that has, maybe maybe their insurance doesn't approve adagrasib, or maybe they had a family member that was on sotorasib and they really want that. I don't have any problem between the two. And I would not switch from one to the other. If someone progresses on sotorasib, I wouldn't then give them adagrasib and vice versa.
Isabel, thank you so much for touching on that. Agreed. This certainly provides our patient with an oral option, but again, we've not seen dramatic overall survival benefit here. Another actionable mutation is EGFR Exon 20. As Rahul mentioned, currently we have amivantamab here, but based off of Papillon study where amivantamab with chemotherapy in frontline setting is showing better outcomes, this is likely to be moving in our first-line settings. And then HER2 mutation, where we have TDXD approved. TDXD recently got bucket approval for all solid tumors with HER2 IHC3+ in refractory settings. Isabel, your experience here, and are you likely going to be using this upfront or save it rather for second-line space?
So we can talk about EGFR exon 20 insertion alterations first.
Yes.
So initially, these patients did not have a targeted therapy in the frontline setting. They had to receive chemotherapy. Amivantamab and mobocertinib. Amivantamab is an infusion therapy, and mobocertinib is an EGFR exon 20 alteration targeted therapy pill. Both of them were only approved in the second-line setting. And now mobocertinib is coming off market. Amivantamab is the only option now. But in order to, now we have amivantamab plus chemo that's getting moved up to the frontline setting. So my experience with this, in full transparency, is that it's tough. Amivantamab is tough in itself. You have the risk of the infusion reaction that typically happens on day one, which is why we split the first dose into day 1 and day 2. And it can be very scary for the patients. And despite giving them singular, 3 days leading up to prevent this infusion reaction, it can still be quite frightening. And typically, if patients have grade 3 or grade 4 infusion reactions to amivantamab, we don't re-challenge them with it. And then we're kind of stuck with looking at, well, what's the next best thing for them? So I would say, I think amivantamab plus chemotherapy is reasonable to try, with a very clear expectation that if they can't tolerate it, I would pull back the chemo and save that for later line and just proceed with single agent amivantamab.
So we are hoping that this paradigm would change with subcutaneous formulation being available. But again, some of those side effects are still real, but mainly infusion-related reactions are rather being minimized with that.
Can I actually jump on that bandwagon for a second? I think that we all need to start to get used to a little more about amivantamab and be more cognizant about the side effects, because we'll see this in more common EGFR space. So these side effects are real.
Right.
And it's not easy. We're not even touching on the idea of increased risk of VTE that we saw with other studies with Mariposa and Mariposa 2. So these side effects for our patients are still very real. And in the community, we need to be cognizant and we need to get used to these side effects and set the right expectations for our patients.
Absolutely. I often just tell my patients right off the bat, you're most likely going to have a reaction on day 1. It's going to feel like X, Y, and Z. This is what's going to happen. And if it becomes this severe, we won't give it to you anymore. And if it's this severe or less, we will consider re-challenging on day 2. But you have to set the stage.
Thank you for touching on that. Coming back to the idea of HER2 mutation, right now, this is approved in second line. Isabel, if you see a patient with HER2 mutation, this is a very small subset of our non-small cell lung cancer patients. Would you rather use TDXD upfront? Are you still using it in second line after chemo-immunotherapy? What's your current practice?
So we happen to have a trial looking at TDXD in the frontline setting. So I had tended to really push for that for our patients. There are other studies looking at other targeted therapies in this space that may or may not be better than TDXD. We don't know yet. But I tend to favor, if you have a target and you have a drug that you're able to offer that can address this target, I would push for that first.
So whenever we're talking about TDXD, we have to acknowledge some of the side effects around this agent as well: fatigue, nausea, alopecia. But it's ILD that's associated with mortality. And in patients with lung cancer that potentially have compromised lung function or might have been exposed to radiation or immunotherapy, Isabel, is the incidence a lot higher for ILD in these patients?
So fortunately, I have not seen it, but I think that's just because I've been, subcognizant of it and so aware of it that I'm counseling my patients about it. But I think in regards to TDXD toxicity, the one that I'm seeing more frequently than ILD is actually nausea, and I think it's undertreated and underprevented. These patients, I feel like, should be, TDXD really should be up there with like grade 5 anti-emetogenic, like same with cisplatin and carboplatin. It is rough. I often give these patients dexamethasone on days 2 and 3 following each infusion. And some patients I've even had to have olanzapine 5 milligrams or 2.5 milligrams at night to help just right around each cycle. So the nausea is something that I really want to emphasize that it's undertreated and a big problem. In addition to that, the cardiac toxicity, you want to make sure you get a baseline echo and an echo every 3 months for these patients to make sure that you don't have any changes in your ejection fraction. And in regards to the ILD, it can happen. I can't say that giving a patient immunotherapy or chemotherapy and immunotherapy before getting a TDXD is going to potentiate your risk of it. But same with radiation. I don't think we have that data, but I'm very forthcoming with my patients saying that ILD is a risk. This can happen. And you are, in a way, getting agents, whether it be radiation or immunotherapy, that could set you up for you developing this.
And again, important to stress the importance of these side effects because, again, it impacts the quality of life, and especially when talking about ILD, which has been related to mortality here. Isabel, now this particular patient has progressed where the disease now in second-line settings, if we have a targetable mutation, we utilize that. What are you utilizing after that? And if they do not have targetable mutation, again, what is your second or third line? We have docetaxel with or without ramucirumab, but again, not the most robust option either.
Correct. So obviously, you know what I'm going to say. I'm going to say look into a clinical trial for our patients with KRAS alterations. We're learning that just targeting the KRAS on the surface is not really enough. We need to look into, combination therapy, right? Do we need to hit RAF? Do we need to hit MEK? Do we need to hit ERK? Do we need to hit all of these downstream pathways to prevent resistance? Because resistance is what we're worried about. So I would always look into a clinical trial for those patients with KRAS alterations. Patients that progress on TDXD, there is some data that you can try TDM1 or trastuzumab for these patients on a clinical trial. And that is something that I've done before. And there are other HER2-altered clinical trials that are available. But let's say these patients are not eligible for clinical trials and we're looking at standard of care options. So yeah, we are looking at docetaxel plus or minus ramucirumab, or gemcitabine plus or minus vinorelbine, in which case you need to make sure you have a Metaport because vinorelbine is a vesicant and you don't want that to cause any issues with extravasation.
And talking about clinical trials, this is going back at ASCO 2022, there was a phase 2 study looking at ramucirumab with combination of pembrolizumab at the time of progressive disease, even once they've been exposed to pembrolizumab. There's ongoing phase 3 study for this. But in your practice, Isabel, outside clinical trials, do you re-challenge your patients with immunotherapy again if they've actually progressed on immunotherapy upfront?
So I think it depends. That's a very loaded question. So let me give you a patient scenario. Let's say you have someone that was treated with upfront carboplatin, pemetrexed, pembrolizumab, received 4 cycles of 3 drugs, and then progressed on single-agent immunotherapy, maybe 6 or 12 months after their carboplatin pemetrexed exposure. At that point, I might consider re-challenging adding the chemotherapy back to the immunotherapy and then getting a short interval scan. And if they have a response, then obviously dropping the chemotherapy portion and keeping going on the immunotherapy to kind of re-agitate the tumor again, maybe.
Yeah, because the argument that we're making here is there's ongoing synergy between all these 3 agents.
Right.
Perfect.
And I would look into clinical trials for these patients. I know I'm a broken record with that, but there's cancer vaccines that are out there, that there's lots of exciting stuff in the IO space. There's tumor infiltrating lymphocytes. There's a lot of stuff. So, just because you progress on immunotherapy does not mean that there aren't other options in the IO space.
Absolutely. Isabel, we've covered a lot here in such a short time. Thank you so much for joining us and sharing your insights. For our listeners, stay with us for a quick recap for today's discussion.
Thank you.
Today, with Dr. Preeshagul, we have covered the latest in metastatic non-small cell lung cancer treatment without actionable mutations in frontline settings. Key takeaway include the importance of comprehensive testing, the strategies for using immunotherapy and chemotherapy combinations, and emerging second-line treatment options.
We've also discussed the impact of new data on clinical practice, particularly with agents targeting KRAS G12C, HER2 mutation with TDXD, and the anticipation around combination of ramucirumab with Pembrolizumab. Thanks for tuning in. Make sure to check out our other discussions in this lung cancer series. We are the Oncology Brothers.